Okay, well, let's go ahead and get started. I'm sure people may be, joining as the conversation begins, but I'd like to start off by welcoming everyone to the first session of the COVID-19 Politics and Policy Speaker Series. We're very fortunately joined by a resident expert, Dr. Zoe McLaren from the School of Public Policy. And I'm going to start off just giving a bit of an introduction and starting with some logistics, which is first to say that this session is recorded. All of these sessions will be recorded. I'll make them available on my website and I'll post that in the chat feature. But then we'll also share it on Twitter and LinkedIn and other social media forums so that you can watch it on your time, or for participants who weren't able to make it today, they'd be able to watch it on their time. We're gonna start off, kind of giving you a broad overview of some of the politics and policies surrounding COVID-19. This really started as a special topics course. It became increasingly clear to me that there were many dimensions of COVID-19 that fit with ideas and theories that we have in political science and the policy sciences. And I thought it would be a good opportunity to use this as a case study to focus from that perspective. But I'm also not by any means an expert on viruses or infectious disease or health policy for that matter. So I opted to try to make use of experts who could come in and share their knowledge. And it became clear that we wanted to open it up to a broader audience within the UMBC community. So to that end, we will have a series of speakers. It'll be every Monday from noon to 1 until December 14th. And you can click on the same link and it will bring you to this WebEx room. So I hope you will continue to join us. We're going to have topics that range from the intergovernmental dimensions of COVID-19 policymaking. We'll focus on the politics of it. We have a former state senator who's going to talk about some of the political dimensions and the relationships between state and local levels. We have presidents of nonprofit associations and trade associations who will talk about implications on public health and economics and entrepreneurship. We have representatives from the university that will discuss the implications for education and higher ed going forward. We have individuals who will talk about the disparate impacts it's had on communities of color, the elderly, and aged facilities. So I think this is going to be a really great series. And the way we're going to organize it is to allow our speakers to present. And after they're done, I'll open it up to questions and answers. So that's all I have for you at this point. I'd like to actually turn it over to Dr. Carolyn Forester to highlight this program that we're putting on from the Department of Political Science.
Thanks, Eric. Okay, so I'm Carolyn Forester. For those of you who don't know me, I'm the current chair of political science, and I'm very excited for this speaker series. And I was very happy to work with Professor Stokan over the summer to, kind of provide the support so that he could move forward with the speaker series. I mean, when we think about what a university is and we think about being together and what an intellectual community is, I mean, we learn so much from interacting with each other. Everybody is working in different ways. And unfortunately, because of our current situation, we're not meeting in hallways, we're not meeting in offices, we're not meeting in classrooms. And so we have to construct opportunities for us to form an intellectual community and to talk about very important ideas. And concerning this particular topic, clearly there is so much that we don't understand about COVID-19 and the impacts it's having on so many different areas of public life. And so I'm just thrilled that, Eric, that you've come up with this idea and that you've now put this into practice. And I just want to thank everyone for being here. Dr. McLaren, thank you so much for being our first speaker. That is wonderful because of our partnership with the School of Public Policy. And it's just great that we can make use of the resources we already have, but it's great that we're going to have outside speakers coming in as well. So I invite all of you, if you're associated with this class or not, to keep coming back. The plan is for us to be here every Monday and to have this kind of conversation from an expert with then the opportunity for a group discussion. And so hopefully what we can do with this environment is create that intellectual community that perhaps we're craving a little bit. I know I am, the idea to talk about big ideas with my peers and my friends and my colleagues, just to hear about what's going on, about the research that's taking place. This is altogether possible that we're going to hear things that haven't been published yet because it's still so new. So hats off to you, Eric, for doing this, and to everyone that's participating in this forum. I invite you to listen and learn and to ask questions and to be part of this every Monday moving forward. And I think it's just really great. So thank you so much for the opportunity to provide this brief preamble, and hopefully this will be a great success. So thank you.
Great. Thank you, Professor Forester. In organizing this series, I really wanted to go with a resident expert who is local right here at University of Maryland, Baltimore County. We agreed that she would introduce herself, but let me just say she's been, very present around these discussions, and I won't be quite the facilitator she might have had very recently, which was Bill Nye. So very glad to have you, Dr. McLaren, and we look forward to your talk.
Thanks, Eric. I'm really happy to be here. Okay. Okay, can you see the slides? Great. So I'm just going to give an overview of pandemic policy for COVID-19. And my Twitter handle's there if you want more of the same, because that's where I post all of my thoughts. So I have a PhD in public policy and economics, and then I was on faculty at the School of Public Health at the University of Michigan. So my background is economics, public health, policy, kind of a good interdisciplinary lens to look at the COVID-19 epidemic. I've mainly focused on fighting HIV and tuberculosis in South Africa, but that actually is very relevant for COVID-19, partly because tuberculosis has respiratory transmission. Both diseases have big concerns that symptoms are not a good sign for people's behavior. And also both of those being fought in a limited resource environment, which in some ways we are here in the US. My focus has been on evidence-based policy, so looking at interdisciplinarily at all of the evidence and trying to decide the best way forward. I don't have a niche saying like this is the one policy I always advocate. I'm always looking at the big picture. And I've also focused on decision-making under uncertainty. So oftentimes with these, you don't have all the information that you want. And so my area of focus has been to kind of look at the evidence we have, assess the quality of the evidence, and then figure out, is there any way we can move forward? What's the best way to move forward, considering that we don't always have all the information we want, and that we can't, in most of these cases, just say, we'll wait and do nothing until we have better information. All of these pandemics require immediate action. And I've been working on COVID-19 since March, a little bit exclusively. So I've had a big focus on testing, on estimating population, so testing programs in general, estimating population prevalence, and then I've been involved in conversations around vaccine development and things like that as well. So big picture policy. So let's just look a little bit at the toll of the pandemic. So I checked last night, 194 dead from COVID-19 officially. So that count does not include excess deaths. Some excess deaths will be COVID-19 related. Some directly kind of undiagnosed cases. Some will be people who've died of other causes, but due to the pandemic. So for example, during lockdowns, being unable to access routine or emergency medical care. There's also a major toll in terms of severe illness, and we do not have very good data on this. That a lot of people have gotten very sick, ended up in the ICU. We have numbers on hospitalizations. We don't have good numbers for people who were very ill, but did not need to or did not choose to go and get hospitalized, which is a very big toll. And even if it's only people being kind of quite ill for 2 weeks at home, that's still a really big burden when we think about the lost work. And also, we're very concerned about the long-term effects of COVID-19, which also aren't very well quantified, but we have enough anecdotal evidence to know that they can stretch for months and months, and they can be very severe. There's also a major economic toll of the pandemic, as we all know, in terms of businesses that have been closed, that have reduced the services that they provide. There's also a mental health toll, so the amount of isolation that people have been facing, or they've had zero isolation because they have home, childcare, family care responsibilities that just make it that they have no time to themselves at all. And then, of course, there's been widening disparities. So the pandemic has caused a great deal of scarcity, and when there's scarcity, everyone's kind of out for themselves, and it's going to widen disparities and inequality. And one of the best things that we can do to address these disparities is to end the pandemic as soon as possible. So is there a role for policy? Yes, definitely. Especially in a situation like this, we really do need the government to play a role in guiding everyone's behavior. Economics 101 tells us that pandemics like this create a lot of negative externalities, so negative spillovers. And the idea is that we need the government to act as a coordinating mechanism and a mechanism for collective action. So the idea that we can fight the pandemic best with no government assistance doesn't make any sense based on standard theory in economics and political science. So how did we get here? First of all, there was a failure to prepare. We knew that a pandemic flu risk was out there. There's been a lot of modeling and discussion around it, but we weren't prepared for the eventuality of that. When we heard about the pandemic flu, it was starting to become a reality even before it hit the US, we had a failure to react then when we knew that the pandemic flu that there was a pandemic flu and that we were at risk. And then there's been a failure to follow just the standard pandemic response policies. Fighting a pandemic is not rocket science. Even when we have a lot of uncertainty about a new pathogen, there's a lot of certainty about the types of things that we should be doing. And so there's a failure to follow those. And then I think also a failure to redirect and change course, which we've had since then. There's been a major focus on primarily individual actions rather than government support. When you think about the things we've been doing in terms of social distancing and mask wearing, the burden of those is falling primarily on individuals and households and communities, whereas things like testing and vaccine development are much more driven by government support. And there's been, yes, some investment in those, but especially in terms of testing, not nearly enough. So people might ask, is it too late to change course? And I will say it is definitely too late for the 194,000 dead, but it's not too late for the next 194,000 dead, if that comes to it. So there's always room for action, and every course correction is a small win that can get us back on track and will save lives. Okay, so where do we go from here? There's an awful lot of things that we do. It is this novel coronavirus, but we've learned a fair amount about how it's transmitted, what policies work, what policies might not work quite as well. And so there's a lot of things that we kind of know what to do and that we could be doing a lot of these policies much better. So a big long list here. I'm going to kind of go through them fairly quickly in this slide, and then I'm going to dive in and give a little bit more detail on testing and vaccine development. So economic support. Basically, a lot of individuals are feeling the crunch of the pandemic, and economic support is one way that while we figure out a way to reduce the spread of the virus and end the pandemic, we can support people, reduce widening disparities, and make the pandemic just a little bit easier to bear for our population. So there's a lot of room there for more economic support from the government. Voting protections are really important. The most important indicator of kind of how long the pandemic is going to last is who is in charge of the pandemic. So it's very high stakes for everybody because the gap between the two different presidential candidates, for example, is really wide in terms of pandemic policies. But it's not just the national level that matters. State and local elected officials also matter. So making sure that there's voting protection so people are able to cast votes and preserve our democratic processes is actually one of the most important things we can do to shape the course of the pandemic one way or the other. So I don't want to talk too much about masks. Masks are very effective. They're very, very low burden for individuals to use. We should have universal mask policies everywhere with very, very few exceptions, if any, period. In terms of social distancing, so we have learned how to stay 6 feet apart. We've learned to avoid gathering in crowds. We've learned to limit the number of people that we interact with. We've learned to stay home and find ways to enjoy ourselves that don't involve interacting with other people. We've learned how to use Zoom for all sorts of activities. So the social distancing is really, really important. If we are not in a position to be passing the virus between one another, then that's going to be really effective at reducing the spread. There have been restrictions on group size, places that people are able to gather. The one area I will focus on there is indoor dining. So that's been, some places have indoor dining allowed with spacing restrictions and some places don't. The evidence we have from contact tracing investigations and from what we understand about the spread is that indoor dining is actually very high risk in terms of transmitting the virus. And so it is likely something that we should think very carefully about whether allowing at all. And for example, if schools are still closed because transmission rates are too high, it probably is very good policy to reconsider whether we have indoor dining at all and think about what our priorities are, because these are all trade-offs we make. The question of indoor dining or kids in schools, for me, that's a no-brainer. I put kids in schools above indoor dining any day. So ventilation. This is something that's just started to get more attention in the last maybe month or 6 weeks, I think. But ventilation is really important. So the idea that opening a window 3 or 6 inches can actually reduce the spread indoors is really powerful. And it's something that's very cheap to do in places that have the ability to open a door, open a window, if you're traveling in a car or other type of public transportation. So opening the window, basically what that does is it increases the air transfer. So it kind of brings in uninfected air and will kind of reduce the concentration of virus in the air. So it's possible for us to get exposed to a small amount of virus and not actually contract COVID-19. So that's kind of the idea behind ventilation. So I think there's more room for learning more about ventilation, but we know that it works quite well. And so we encourage everybody to think about using that policy. And we also want to think about upgrading buildings and buying ventilation systems, portable ventilation systems and things like that to fight COVID-19. So testing and rapid testing. So this is the process of testing people to figure out whether they have been infected with the virus that causes COVID-19. When I say testing overall, that would include lab-based processing, the PCR tests that most of us have kind of become familiar with throughout the pandemic. It also includes rapid testing. So rapid testing is the idea that you would get a result back within an hour, within 15 minutes, whether or not it needs to go to a lab. So you may have a lab on site that can turn things around quite quickly, but usually those are going to not require a lab. So there's kind of 2 different types of testing that can both achieve very similar things in terms of reducing the spread of the virus. Contact tracing. So contact tracing is very powerful if done well. A lot of places have not really invested in contact tracing, and so it's been a little bit anemic in terms of its effect. But contact tracing is really important. We think about contact tracing as a way to let people know that they've been exposed so they can get tested and either get care themselves if they need it or prevent further spread. And I think about contact tracing in some way as a pandemic concierge as opposed to a kind of punitive system. The idea is that we would really like to make amends for any spread that we've accidentally done or done because of our carelessness. And so contact tracers can really help us think about who we might have transmitted to and how to communicate to them that they should probably get tested because they may have been exposed. And learning about possible exposure is one of the main drivers that gets people to actually get tested, for example, even if they don't have symptoms. And then, of course, there's vaccine development. So I'm almost certain that everybody here has put too much faith in vaccine development relative to the other pandemic policies. And so I'll talk a little bit more about that in a few slides. Sorry, and that was a very, very quick overview of policy, but even with the uncertainty that we have, we know that there are a number of different policies that work, and we should be investing in all of them. Okay. So testing. First of all, I talk to a lot of people who say, oh, testing in my area is actually really good, or Georgetown's doing really good testing, or New York's doing really good testing. There's basically almost nowhere in the entire US that is doing kind of the level of testing that kind of the minimum level of testing that we should expect from our governments. So everywhere we've kind of set fairly low bars. Some places have met those low bars and many places have not. So the idea about testing is there's kind of two main purposes for testing. One is diagnostic purposes, and so that's generally in a medical setting with people who are concerned that they're infected, want to get tested, they have symptoms, they have medical concerns, and we need a pretty high level of accuracy, basically because we want to know if it's COVID-19. But in a lot of cases, we actually want to rule out COVID-19 because they have symptoms of something else that we can also treat. So diagnostic purposes is generally in a medical setting. And that is different from screening purposes. So screening tests are the idea that we want to test a high proportion of the entire population. We're basically kind of proactively going out and looking for new cases, which is very different than the diagnostic purposes, which is waiting for someone to show up in a medical setting requesting care. So basically, everybody wants to know if they're contagious. Most of us are interacting with people that we love and care about, and most of us don't want to transmit the virus to people that we love and care about and are friends with and work with. So basically, everybody wants to know if they're contagious. They may or may not want other people to know whether they're contagious. That's a separate question, but everybody would like to have that information. So symptom-based testing is not going to be sufficient for COVID-19 for two reasons. One is that we think about 40% of cases have no symptoms at all, no fever, no cough, they feel fine, they're running every day, and yet they're infected, they're contagious, they're spreading the virus. So relying simply on symptoms is going to miss that 40% of people. The other 60% of people have some of these COVID-19 symptoms. The problem is that a lot of them have what we call non-specific symptoms. A headache, which could be caused by any number of things. A cough also could be caused by any number of things, especially other things as we get into flu season. And so even people who have symptoms that they notice cannot be sure that it's actually COVID-19. So there are some studies that have tried to figure out like what's the likelihood if you have a fever and a cough that it's COVID-19, but part of it that depends on the local prevalence. It depends on how old you are. It depends on a number of different things. And so even symptoms are not often going to be a strong enough signal to get people to, for example, stay home or immediately go and get tested. If you get a headache, you might think, well, it's just a headache. It could be COVID-19, but maybe not, I'm not sure enough. And so the idea is that testing is helpful for those people as well, that they have some kind of symptom that doesn't seem like it could be COVID-19, but it might be. And so we want them to get access to tests as well, because maybe the headache itself is not enough to get people to isolate, but the headache is enough to get them a test, which tells them that it's COVID-19, and then that would get them to be more likely to self-isolate. So I have in mind this food truck model of testing. There's been a very little thought leadership in the US around testing. So people don't really understand the power of testing, how testing systems should work, what the kind of minimum testing program, kind of what the bar for success should be. Our national government has had an aversion to testing, which has made it difficult for all of the other states and localities in this country to develop testing programs that really meet the needs that we have during a pandemic. And so I have in mind this food truck model. And the way we think about it is that there would be kind of the equivalent of, in the pre-pandemic times, how easy would it be to go somewhere and get a taco? There's food trucks, there's places that sell tacos. The idea that you can kind of swing by and pick up tacos without too much trouble. The same idea around testing, that we would have maybe mobile health units, kind of food trucks that would be in specific locations at specific times, would be into the different neighborhoods, and people could go swing by and it would be within 15 minutes, you would get a test, you would get your results back within 24 hours, and you could go by at least weekly. So that would be kind of a minimum level of testing. So I guarantee you that nowhere is meeting that quality of testing, except maybe some of the college campuses right now that are doing required testing are meeting that. And the idea would be that would be a level of testing that would help us kind of end the pandemic. So there's been some talk about at-home testing. The issue is that at-home testing is not really supported by the evidence. There are a lot of drawbacks to at-home testing, and basically you can achieve almost as much convenience with a food truck model as with at-home testing without most of the drawbacks of at-home testing and the obstacles to getting to at-home testing. So the food truck model is kind of a place to start. If we can achieve that, then we can kind of figure out from that point how to improve the testing programs. And for rapid screening tests, it actually only requires moderate levels of test accuracy. So that may be a little bit surprising because everybody's always focused on kind of test accuracy, but the way to think about rapid screening testing is it basically splits the population into a group of people who have high likelihood of being contagious and a group of people who have a low likelihood of being contagious. If we have perfect accuracy and it's like these are all every single contagious person and then everyone else isn't, that can end the pandemic really quickly. But with lower levels of accuracy, we're splitting it into kind of high and low. And the idea is the high levels of test accuracy, the high levels of contagiousness, people would have a layer kind of more kind of social distancing and isolation than we do now. And the rest of the population would have a lower level required because the prevalence in that population is smaller. So the idea is it's kind of like bailing a boat with a leaky bucket, that if our tests are only moderately accurate, we can kind of only catch so many cases at a time and only achieve so much isolation because people may be concerned that they're a false positive rather than a true positive. But the idea is that just prolongs how long it takes. But as long as everyone kind of goes along with the system in general, as long as most people or a sufficient number of people go along with the system, we can actually reduce transmission. So even if some people are not going to self-isolate, as long as most people are going to do some form of self-isolation or at least increase the level of self-isolation, we can actually bring the pandemic, reduce the spread of the pandemic really quickly. And the idea about testing is a lot of people think that this kind of testing is like an ongoing thing, that we would all need to get tested weekly or every twice a week. But the idea with testing is that once we're able to kind of get the prevalence of the pandemic down, we can actually reduce the intensity of testing as well. So the whole point with testing is you kind of adapt. If you have a high prevalence, you're going to be testing more frequently. And then if you test frequently enough and bring your prevalence down, then your intensity of testing reduces as well. And so the idea is it's a way to kind of bring the pandemic to an end sooner rather than later. So I am a very big proponent of testing, and it's not because that is a little bit the background that I have. It's because kind of looking across the board at all of those possible policies that I listed in that first slide, testing really is one of the ones that is incredibly powerful and gives us kind of a lot of benefit right away. So basically, a strong national testing program can end the pandemic without a vaccine. So there is news out of Canada, there's news out of New Zealand. These are countries that have kind of brought the epidemic and several countries in Asia as well have basically, and Senegal, have brought the pandemic under control without access to a vaccine. So it is possible, and testing is often a really big component of that. So one of the reasons is that testing is a way that we get fewer deaths because we're able to catch cases and slow transmission. It gives us more freedom because we're able to figure out who's contagious and who isn't, and obviously less freedom for people who are contagious for a short period of time because they're only contagious for a few days, and the rest of us a lot more freedom. And then also saves money because it brings the pandemic to an end sooner. So basically, there is no catch with testing. It saves us money, so it's not it's additional cost in terms of paying for the testing program, but relative to the cost that we're paying with kids not in school and people working from home and businesses closed and things like that, it's actually cost savings. And we get both more freedom and more deaths. So it's not particularly burdensome. And you can imagine that we're basically, rather than thinking, oh no, we have to kind of add on additional testing burden on top of everything we're already doing, the idea is that adding on that testing means reducing the burden in other ways. We can open more types of businesses, our economy can recover more quickly. And so it really is, there is no catch with testing, which is part of why it's been a little bit puzzling for me that so many people are kind of not quite as excited about the possibilities of testing. I think people kind of don't fully understand how powerful it is. The other thing is that testing builds its own momentum. So basically, if you start off just testing a small number of people, you're going to be able to have fewer deaths and more freedom within that small group, and actually reduce the amount of testing you need to do to keep the pandemic under control once you reduce the prevalence down. And other people, even if they didn't jump on the testing bandwagon early on, may look to those areas and say, wow, okay, their lives are so much better. It didn't seem like it was particularly burdensome. And they're going to want to implement testing policies as well. So it's kind of very obvious testing can work really quickly and bring a lot of freedom quite quickly. And so people will kind of see that, and it does its own PR in some ways. And it builds its own momentum because when you do a high frequency of testing and you drive prevalence down, you actually can then reduce the intensity of testing in order to keep the pandemic under control. So basically, the more you do, you drive the pandemic down, and then it's actually less costly. And the other thing that I really like about testing is that it fights fatalism. So fatalism is basically this idea that like nothing we do matters. The pandemic's going to go on, and our individual actions don't matter at all. Which is, of course, not true. All of our individual actions matter a lot in terms of reducing the spread, but people can kind of start to feel like it doesn't matter. When we're using things like social distancing and masks, it's not always clear how many cases you've actually prevented. But the idea with testing is that you will actually see progress happening pretty quickly. And testing also measures the progress that you're doing. So the idea with testing is that you're going to start to see progress, see that testing works, and people will feel a little bit of hope that there actually is a way through this pandemic. And I think that that's really, really important because a lot of it is that people need to be motivated to wear their mask, to do the social distancing, to postpone social gatherings and things like that. And the more that they have hope that we can get through the pandemic sooner, the more they're likely to invest in those other interventions. And it's kind of the same thing about self-isolating. So there is a concern that people will get tested, find out they're positive, and then just not bother self-isolating. But if we see the engine of testing start to work, then people say, oh, I see testing works. I can see that if I self-isolate, I get the benefit of lower prevalence overall, and we get back to normal sooner. And so basically that's part of building its own momentum, that people will be inspired to do more self-isolation. Okay. So everybody always wants to hear about vaccines, but actually before I even click to that slide, I like to talk about testing first before talking about vaccines, partly because I think everyone's put an awful lot of focus on vaccines themselves as if that's the only way that we can get out of the pandemic. And they get really stressed when they hear any bad news about vaccines and how quickly it's coming. And so basically I want to make sure that I've communicated that testing alone can help us end the pandemic, even without a vaccine. And when the vaccine comes online, having testing will help. Testing and the vaccine are complements, will help us drive transmission down quickly as well. So if you are stressed about the vaccine, it definitely makes more sense to kind of focus more on testing. And testing is a lot less uncertain than the vaccine. There's a lot of uncertainty around the vaccine that I think stresses a lot of people out. And when we think about kind of decision making under uncertainty, if we're going to put all of our eggs in the vaccine basket, then that can actually be a very risky strategy. And it makes much more sense to put a lot of eggs in the testing strategy basket, which is something that is kind of tried and true and works. And we have time to course correct with our testing policy in a way that we don't always with vaccine policy. So first of all, the #1 vaccine policy is get your flu shot early. So I think kind of as we get it, most people procrastinate. So if you're someone who can actually get it early, that's great. It'll make it a little bit less of a madhouse when people kind of get around to getting their flu shots. And also, we're not sure what's going to happen in terms of vaccine distribution later on this fall. So there have been, the president is trying to make sure that everybody is ready to deliver a COVID-19 vaccine starting in early November. And so that just may add kind of additional layers of uncertainty that are going to make it more complicated to get even a basic flu shot. So I highly recommend get your flu shot early. Get it in the month of September. So We're currently in phase 3 of a clinical trial for a new vaccine for COVID-19 here in the US. So there have been some suggestions that maybe phase 3 is not necessarily needed, that it's safe and effective enough based on the phase 1 and phase 2 data. Basically, phase 3 is there for a reason. Phase 3 is when we actually learn whether the vaccine is safe and effective. Before phase 3, phase 1 and phase 2 is only a few hundred people. It's not nearly enough people to get a good sense of how this would play out if we gave it to the entire population. Some people have focused on the fact that phase 3 is 30,000 people and saying, well, if it's safe enough to give to 30,000 people, then isn't it safe enough to give to everybody? Shouldn't we just approve it? But the idea is it's actually technically not safe enough to give to 30,000 people unless you have very high levels of monitoring that we do in phase 3. And even then, those high levels of monitoring, we don't know whether it's safe enough. We haven't given it to enough people. 30,000 people is a lot, but it's actually the minimum number needed in order to get a statistically significant signal around safety and effectiveness. So it's actually the minimum number. And then the trial is prepared to pause or stop if any kind of adverse effects, if any concerns about safety arise. So there was the two trials, I think, paused in the last week. And that was that one single person out of those almost 30,000 people had an adverse effect, and they paused everything to kind of look in and figure out what's going on. That should give you a sign that we don't know for sure that it's safe, and phase 3 is super, super important. Anybody who says that before phase 3 we quote unquote know that it's safe and effective, we don't know based on our standard levels of statistical significance. So we have kind of levels of evidence required to actually know to a degree of certainty whether it's safe and effective. It's really important that we protect the integrity of the FDA. So the FDA is the organization that's going to approve the vaccine. And that is the signal that we're all going to get about whether the vaccine is safe and effective. And that is a pretty important driving force in people's decision to get it or not. If there are concerns about political interference in the FDA, then that signal loses its value. So an emergency use authorization, an early approval, or even the full approval from a kind of questionable process at the FDA is really going to dampen demand for the vaccine. So we want to make sure that we protect the integrity there. There's a lot of safeguards built in to make sure that the vaccine process goes as planned. And basically, even though we're in the middle of a pandemic, it's really, really important that we actually complete the full process. You look at the cost-benefit analysis, and it doesn't make sense to do this emergency use authorization because people are not going to necessarily trust that signal of safety and effectiveness enough to reach the levels of take-up we need for the vaccine. So we're trying to reach vaccine-driven herd immunity. And the idea with that is that herd immunity is not just about you, it's about everybody around you. And so part of the idea is that we're not just thinking, oh, I want the vaccine, but we're thinking, oh, I want everybody around me to want the vaccine. So the idea here is that we want to make sure the process is going to give broad confidence in the safety and the effectiveness of the vaccine to make sure that we have really high demand and can reach really high take-up of the vaccine. It's important to remember that the vaccine is unlikely to be 100% effective. The FDA has said that it's willing to approve a vaccine that's as low as 50% effective. So that still will help. It'll be kind of one additional layer of policy that will fight the pandemic. But of course, having a vaccine that's 50% effective, we're still going to be needing to do social distancing and mask wearing, these other types of things. But the lower the level of the effectiveness, we can actually kind of boost the overall population level of effectiveness by getting really high take-up. So if we end up with a vaccine that turns out to only be 60 or 70% effective, we can actually increase the kind of overall population effectiveness much higher. And the idea is that by getting really high take-up of the vaccine, we make it really hard for the virus to find new hosts. And it's that same idea about herd immunity, is that the transmission chains die out because they can't find anybody the virus can't find anyone to infect. So the idea here is that regardless of the level of effectiveness, we really want to aim for really high take-up of the vaccine. If I had to choose between whether I would get the vaccine or the 10 people that I interact with most get the vaccine, I'd probably choose that everybody around me get it and me not get it, because that's basically, if everyone else around me is protected, then I'm automatically protected. We have major concerns about vaccine hesitancy. So that is the term that encompasses the people who refuse to get the vaccine no matter what, the people that are okay with getting the vaccine but maybe want to delay and wait, and the people that are just kind of unsure. They're not gung-ho about getting the vaccine, they're just hesitant overall. And so the vaccine hesitancy is a force that's going to make it really difficult for us to get really high take-up. So we want to think about, with the process, about what we can do to get high enough take-up of the vaccine. The people who are hardcore anti-vaxxers are likely to not want this vaccine at all, and there may not be much that we can do about that. But there's a lot of people who are very reasonable who would say that if they trusted the FDA or trusted the vaccine was safe, they would definitely get it. But if they had concerns about whether the vaccine was prematurely pre-approved or whether it was actually, whether the information we got was true, that they'd be a little bit more hesitant about getting it. And so we want to do whatever we can to make sure that people trust the vaccine and are willing to actually get the vaccine. And that's part of why protecting the integrity of the FDA is so important. You might think, oh, rushing the process is actually going to get the vaccine out sooner and get us to vaccine-driven herd immunity sooner. But the idea is that take-up is really what matters in some ways most. So if we have a vaccine that's pre-approved but nobody takes it, we get no protection from that. And so the idea here is that taking a little bit longer to do the full process that gets everybody on board with the safety is actually much, much more worth it in the long run. And also, this is just the first of probably several COVID-19 vaccines that are going to come on the market. And if we basically blow the integrity of the FDA on this first vaccine, then it's really going to hamper subsequent processes. And so we really want to make sure we think about the long run, and that the whole point here is ending the pandemic. This single vaccine may or may not be the thing that does it. It's probably going to just be one additional tool that we need. And the FDA is also involved in approving rapid tests and things like that as well. So protecting the integrity of the FDA is paramount if we care about ending the pandemic. Once we have the vaccine approved, the process of vaccine manufacturing and distribution is no small feat. So that's also going to be a major concern. And based on the track record of the current administration in terms of scaling up testing and things like that, I'm really concerned about the manufacturing and distribution process as well. So I'm not optimistic that that's going to be able to, even if a vaccine was approved in the fall, that manufacturing and distribution process would happen enough to be able to kind of end the pandemic anytime in the spring. So when I think about vaccine development, I'm thinking that we need to not think about, well, when might a vaccine be approved, but something like 2 to 3 to even 4 months after that is when we'll really start getting the benefits of a vaccine. Also because the current vaccine requires 2 different shots kind of between, I think, 1 and 6 weeks apart. So you don't get the full effectiveness from that first shot. The idea here is that the vaccine looks like it's more delayed than a lot of people think. And in some ways, our best bet is really in the meantime to invest in testing. If we have a robust testing program when the vaccine becomes available, then the combination of those can drive transmission down and the pandemic really quickly. So the idea that we would just kind of do nothing, white knuckle our way through, and then the vaccine is going to come like a white knight and save us all is really not a good way to think about it. You're going to end up making a bunch of choices that I guarantee you will regret. Whereas focusing on things that we can do that are really reliable, that there's very little uncertainty about, like things like testing, is actually a pretty good way forward. So in terms of policy priorities, number one is protecting the integrity of our election. The most important driver of what our pandemic policies are going to look like in the length of the pandemic is who is in charge and the decisions they're making. Focusing on testing and rapid testing. So there's a lot of new rapid testing technology that's about to come online. Some of it just has. And so really investing in beefing up our testing systems and demanding better testing quality and capacity from our elected officials. We absolutely need to get kids back into K-12 schools as safely because it's a huge burden and really is going to have long-lasting impacts. But that safety part is important. And also, if parents don't feel that the schools are safe, they're not going to send their kids back to school. So the idea is that it needs to be safe and it needs to be perceived as safe by everybody involved. And the last thing is providing a lot more economic support for those who are hardest hit by the pandemic, because we're really seeing kind of some people's incomes have not been affected and some have been totally decimated. And so there's a lot more room for policy in that realm as well. Okay, happy to open it up to questions from the audience.
Great. Well, first, let me just thank you, Dr. McLaren. This was an absolutely wonderful talk. I'd also like to just take a moment and thank Dr. Mallinson, the director of the Center for Social Science Scholarship, for helping to promote the event as well. And I'll just lead off with one question, if that's okay. Obviously, one of the core focuses you had was on the testing side, and I know there has been some questions centered on the positivity rate and which ones we should be focusing on when making some decisions within the state of Maryland. So Johns Hopkins has their positivity rate, whereas the Maryland Department of Health seems to have a different one that's tied to whether we should consider those rates just in terms of the kind of at an individual level, or if you're tested multiple times, should that be included in the denominator? But it seems to potentially have some implications for government decision making. And I was curious if you had any thoughts on that. And then we'll open it up to general questions.
Sure. So test positivity is actually the best statistic we have to give us real-time decision-making information about the pandemic. So basically, it's kind of our best estimate of transmission. I don't have time to get into all of the details around that, but I think in some ways it's understood by most people on the ground, and actually in some ways a lot of experts as well. But that's kind of a measure that I've used in the past with my work in tuberculosis. And basically, it's something where kind of all of the things that we can do to slow the spread, they all feed in and will affect test positivity. And so that's the number that I look at kind of when someone says, is a state doing well? Is a city doing well or not? I look at their test positivity number. And so it really, really is a powerful measure. And if it's high, then the idea is that we need to do all the things that we know to prevent transmission. And one of them is just scaling up testing. It seems like a bit of a cop-out that your test positivity is high, so like let's double the amount of testing we're doing. It mechanically drops your test positivity rate down. But that's kind of the point, that you scale up your testing, you're going to find a lot more cases. They're going to be able to make different decisions, hopefully self-isolate, prevent the spread, and that's going to kind of reduce the number of cases you have in the future, and your test positivity comes down. Because testing is the engine for self-isolation, is the engine for reducing the spread. So if we have high levels of spread and high test positivity, then we can scale up that engine. It's both measurement and the engine for self-isolation. So I think that's a good place to look. Basically, that people, negative tests, people can be retested if they're still negative. Once they test positive once, they shouldn't be back. Then that's kind of, they have a case, and we shouldn't include repeat positive tests in the denominator. So there's some details, but most of the test positivity data gives us some guideline, especially if we look at how test positivity is going up or down, even if we don't look at the specific number. But yeah, it's incredibly powerful.
Great, thank you. Well, I'd like to open it up. I know there's not a lot of time remaining, but are there particular questions? If not, I saw one that came in, but let me open it up first. Okay, well, I'll go ahead and ask the one that came in. So they would like to know about travel restrictions, and if any you think should be in place between U.S. states. Obviously, there's a potential constitutional question that exists here as well.
So I think the issue about travel restrictions is that they are not easily enforceable, and there's constitutional concerns around that as well. But I think they're actually very helpful as a guide for behavior, even if they're not significantly enforceable. Most people are not aware of kind of which states have high transmission and which states have low transmission. So it's an easy way to communicate to people about kind of where high risk places are. And in general, we want to restrict travel as much as possible. I want people to stay local as much as possible. It's the traveling that initially spread COVID-19 around the world, and will continue to spread it throughout the US. So I don't think that they're necessarily enforceable, but I think they're really useful as a guide, and also encouraging people, if they are traveling, to make sure that they get tested. And the other thing is that I traveled to Michigan over the summer to visit friends in a kind of quarantine vacation pod. And I did a 2-week quarantine before I left. And then I didn't do any indoor pit stops on the way. So I basically was like COVID free for sure when I arrived in Michigan. And that is one way to think about traveling, that you need to do the quarantine to make sure that you don't spread it. So there's ways to travel while doing it very responsibly.
Great. Well, I'd like to open it up to more questions.
It's Carolyn here. Zoe, that was great. Thank you so much for that treasure trove of information. I have a couple questions regarding testing. I really appreciated your central message that ramping up testing can be much more quickly achieved than, say, a vaccine might come in. And I think that that's an important message to really take home. How close are we? Like, how available is testing across the United States right now? Like, for example, in Baltimore County, I know I got a test, like for exactly for the same reason that you said. I went to visit some relatives, just wanted to confirm, I socially distanced quite a bit, but I just wanted to confirm. And here in Baltimore County, I was able to go someplace and get a test. And then 3 days later, I had the answer. How close are we to the food truck model? And my supplementary question to that is, how expensive are these tests anyway? Like, when are we going to get to the point where, because you said like the food truck model would be, in a community, we could potentially go every week, but that assumes that there's enough tests, that there are enough tests, and that they're cost effective enough. And I was wondering if you could say something about that. And also one more question. Sometimes you hear about the diagnostic test versus the antibodies test. Could you say something about that distinction? Because it seems like you're talking about the diagnostic, like, do you have COVID right now, is the question, really, not how many antibodies might you have, and is that going to decrease over time? Can we get reinfected, and questions like that. So I know that's a lot together in one question.
Nope, I got it.
Gotcha. Thanks.
So I'll deal with the second question first. So basically there are tests of current infection and tests of past infection. The antibody test is a test of past infection, and I didn't talk about that one at all today. We're talking specifically about the current infection, because current infection is telling us about, are you contagious? Are you currently infected? Do you need medical care? Are you currently contagious? Within that, there are diagnostic and screening tests. And the idea is that we have, they're called antigen tests. So antigen tests and antibody tests are different. It's endlessly confusing. But the idea here is that we're just talking about the tests of current infection. It can be diagnostic or screening, can be PCR or lab-based. They can be antigen tests. The antibody test is a totally separate thing, which is, are you infected in the past? And that's not something we care about when we're thinking about kind of, do you need medical care, or do you need, or are you contagious? So in terms of how close we are to the food truck model, well, that's something, it differs everywhere where you are, but think about it. So if you wanted to get a test tomorrow, where's the easiest place for you to get a test? How long would it take to get your results, and what would it cost you? That's information that you can try to figure out. And if, first of all, it's hard to figure that out, then testing's not great. If you can't get a test quickly, if you can't get your results quickly, and if it's going to cost you a lot of money to get it, then that's far from the food truck model. So basically the question is, you can answer that question for yourself. And if you have trouble answering that question, your access is not good. So basically there should be, like the ice cream truck going around with the sound. You're like, oh wait, I hear the food truck. I'm going to go swing by and get tested because it's whatever day of the week it is today. I have no idea, Monday. And I'm a Monday person. I get tested every single Monday or something like that. So that's kind of the idea. And then the whole point is that we can get closer to the food truck model if our elected officials are going to invest more in that. And so part of it is not like, well, how long is it going to take? Well, how many phone calls are you going to make this week? How many people are you going to talk to? That really is, it's like, if we demand the food truck model, then that's something that's like a clear message. We can demand it from our elected officials, and we can hold them accountable, because we can say, well, 2 weeks from now, then how easy is it for me to get a test, and what's it going to cost? And when we think about the actual cost of testing, the whole point is that testing ends the pandemic sooner. It opens up Broadway in New York City. It gets our kids back in school. It gets us all back on campus with all of the benefits that entails. So the idea is that even if testing actually costs money to these programs, but it is a small amount relative to the cost that we are just incurring every single minute that we're still in the pandemic. Like, what is the benefit of ending the pandemic 3 months sooner, or 2 months sooner. And that is kind of part of the benefit of testing. So basically, kind of any way you look at it, testing saves money overall as a society.
Great, thank you. And I do want to just briefly, before we wrap up here, post in the comments for those of you that might be interested in the future speaker series. Next week we'll have a state senator, former state senator Stephen Vita from Michigan, who will talk about the politics. I did see one more question come in, which I think was sent to everyone, asking about restrictions on group size. And I think the particular question is about recent protests around the country, whether these types of protests and mass gatherings should be shut down. So obviously this goes beyond kind of just a public health consideration that we would have, but do you have any thoughts on that, Dr. McLaren?
Sure. And I will say, I know we're supposed to end at 1 o'clock. I'm happy to stick around in the WebEx the way I would at the end of an actual seminar, and we can maybe turn the recording off and I can answer any more questions that people have. If you want to stick around, I'm happy to stick around for a little bit to answer questions. So in terms of the protests, basically there were huge numbers of protests all over the country around racial justice earlier this year. And then we followed the numbers very carefully to see what impact that would have on the transmission of COVID-19. And it turned out that we didn't see these big spikes that people worried that we were. So basically the idea of people being outdoors, everyone wearing a mask, socially distanced, that actually was not a major driver of spread of COVID-19. So part of it is that we know how to do some of these outdoor activities in a way that is fairly safe if everybody follows these precautions. And so the question is, well, should we outlaw these types of protests? Well, basically not from the point of view from COVID-19, that there are ways that they're basically not a major driver of transmission. This is different from some of the kind of large group gatherings where people are unmasked, where they're not doing social distancing, that those can be a major driver. So part of it is the idea that we have these kind of numbers, kind of maximum number of numbers of people that can gather together. But basically the idea there is that we need to reduce the number of people. So if there is a spread, it doesn't result in as many cases. But if we layer on other policies, there's good ventilation, we're outdoors, we're spread apart, we're wearing masks, then it makes those types of gatherings, and if we're not like shouting or singing, which is also risky, then it makes them even more safe. So I think we have more nuanced views on kind of, it's not a clear dichotomy, but the idea that there are certain types of activities that are safer than others. And it really comes down to what is the expected amount of transmission from that particular gathering. If you're gathering in a place that has very, very low prevalence, then a larger gathering is actually safer than if it has really high prevalence. So we need to take all of these factors into account and create guidelines about kind of what's allowed and what isn't.
Great. Well, let me thank you on behalf of everyone for participating today, Dr. McLaren.
My pleasure. Thanks for having me.
Very glad to. We're very fortunate to have you as a local resident expert here at UMBC. So with that, it will formally conclude the first session. Please join us again next week and every week until December 14th. Again, I've posted in the chat box the speaker series. And I'll certainly stick around as well to hear any additional questions. At this point, I'm going to stop the recording.